started. Again, as in most of these sections on the exam, it requires both recall, and in this part of devices, it's primarily recall, but also application and analysis. Now, when you're thinking about getting medication deposited in the lungs, a lot of it has to do with how big are the particle size. So they have to be within what's called the respirable range, meaning it gets into the portion of the lungs where it's going to do the most good. You also have to make sure that you're using the appropriate device for the situation, as well as that they're doing it correctly, and it's also appropriate for that patient. For instance, for an elderly person who has bad arthritis, you have to keep in mind what can they do, how much grip strength and how much finger strength do they have to be able to push down an inhaler, or if they're an amputee and only have one hand, how do you help them determine what's the best to use for their asthma? So sometimes you come across some really interesting dilemmas that you should be able to help your patients and providers determine best device and medication. So when you're looking at particle size, if the particles are larger than 5 microns, it's really not going to get down into the lungs. It's going to stay primarily in the upper airway, which means it most likely will be swallowed. If it's less than 2 microns, it's getting down into the really lower terminal bronchioles and alveoli. That's not where the medication can do the best or be the most efficacious. So the respirable size is between 2 and 5 microns, where it's getting into from the upper airways to the lower airways, but not so small that it's getting into the alveolar sacs. And as I mentioned earlier, you have to choose the correct device for that particular person. There are NIH guidelines for use depending on the patient population or individual person's abilities or lack thereof. Also, how portable is it? How easy is it to use? Where is this medication going to be used? Is it only going to be at home, or is it also going to be used away from home and needs to be portable? And then how much of the medicine is available in the device? Again, as I mentioned, certainly there's some geriatric, there's certainly pediatric issues to consider. The person that's disabled, whether it's a mental disability or a physical disability, hand-lung coordination. So if you have a person that you want to spray and take a deep breath at the same time, you have to have really great hand-lung coordination to do that. And if there's any lag time between spray and inhalation, you will not get the full benefit of medication. So how do you get around that? What kind of things can you help the provider, if you're not the one prescribing, determine what is the best? And certainly costs. There's very few things out there of inhaler type that is less than $200. So if you don't have insurance, or let's say you have insurance, and in my world this is not uncommon, this medication, let's say Flovent, has been on their insurance list, on their formulary, and they've done really well, and I've had this happen, but now it's off, and the only thing I have for that age group in that category is Qvar, and so we have to switch to Qvar, which may or may not be as good, or could be even better than the Flovent, but you have to put all that in the mix also. How much does it cost? Is it available on their formulary, etc. So again, part of the ability to get the medication in the lungs is how well can you inhale. You know, how fast is your inspiratory flow and how much of a resistance is in the device you're considering. And on the right-hand side, you can see that depending on the type of medication we're talking, discus, FlexHaler, AutoHaler, etc., there's optimum inspiratory flow. And each one of these has a little bit different in their resistance. So again, then how do you determine? Well, guess what? There's actually a little thing that you can use called the in-check dial. So the in-check dial is a nice little tool to use to determine what is this patient's inspiratory flow rate like and what can they do. So on the dial, on the little tool itself, it has this table and goes through the different types of inhalers and what is the optimum inspiratory flow. And then on the piece that you blow into, you can dial it to the different types and see how well they can meet up or match up with the optimum inspiratory flow. So you can actually, with this in-check dial, be able to determine which of these are more appropriate for this patient and which do you need to stay away from. And the nice thing about it, it also helps you teach the correct technique, but you can get this one instrument, but you can purchase these disposable one-way check valves. So you just put the check valve on the end, and that's what the patient puts his or her mouth around, and it's disposable, but you didn't have to buy a new tool. So these are really nice tools to use in a variety of situations and a variety of age groups. Now, it used to be that all inhalers were CFC, fluorocarbons. I used to know that, and I haven't needed to know that because we haven't had CFC for quite a long time. I would say 4 or 5 years ago, all of them had to have switched over to HFA, and the reason is that the CFCs were affecting our ozone layer, adding to our ozone layer, supposedly, and so HFA, everything had to switch to HFA, and there was a certain time limit for these manufacturers to switch over their propellant to HFA. That was one way we were able to get rid of Primatene Mist. It was too expensive for Primatene Mist, which was a racemic epi inhaler that you could buy over the counter. They wanted a dispensation to not have to abide by the ruling by the FDA. And a lot of us, including AAE, we commented to the FDA and said why we did not want to see Primatene Mist on the market. And they were not given their waiver to continue CFC, so they went off the market. So that was one of the good things. Though one of the bad things about switching from CFC to HFA is prior to the switch, we had albuterols that were generic. But when they had to switch from CFC to HFA propellant, now the albuterols are back on brand. And until we reach the time period where generics are now available, the patent is up. Right now, everything is still brand. Now, it also used to be thought, and part of it was the CFC, is that if you sprayed and had the open mouth technique so that your mouth was open and not around the end of the inhaler, that the way CFC sprayed out was fairly narrow. So it would go right into the mouth, With HFA, the spray is more broad. So if you did the open mouth, some of it would go over here onto your cheeks. So if you're going to not use a spacer and just use the inhaler, then the mouth is to be closed around the end piece so that you do get the benefit of the medication. A lot of different devices. So here are the multi-dose inhalers. And almost all of them, at least the inhaled corticosteroid inhalers, have some form or fashion of a counter. The Zoconex, which is levalbuterol, and the Proventil Sabas do not have counters, but I'm not sure. So Proventil does not, Ventolin does, and ProAir have counters, but the other two do not have counters, and that's a detriment in my thinking. You have to know how much you have in there. It's hard for people to keep track of how much they've used. Okay, so here are the multi-dose inhalers, and there's a number of them, and you need to know what priming is and how much to prime for which brand, and also how to clean. So when we're talking Advair, this is not the discus, this is the inhaler. Alvesco, Aerospan, and Dulera, here is how you prime. So when you take it out of the box, before you ever use it, you spray so many sprays, and it tells you how many. Now, after you've done, let's say 4 for 2 for Advair, and those first 2 puffs that you spray out in the air, you cannot say that there's a full complement of medication, full dose of medication in either the first or that second spray. But now that you've primed it, that 3rd spray that comes out is full dose. So now it's ready to use. So you prime it by doing 2 sprays out in the air, now you're ready to use it, and you can say you have full dose. Now, it shouldn't happen that you don't use Advair for 2 weeks, but if for some reason you don't, then you would want to prime it again. If you drop it, the manufacturer says you should prime it again. And if you go through all of these, you'll see how many the manufacturer recommends for priming and what to do if you've not used it or if you have dropped it. Cleaning, I don't know if you're as old as I am, but it used to be said that you would know how much was in your inhaler by putting it in a sink of water, and if it floated, you had no medication. If it sank, you had medication. Well, number 1, that's wrong, and number 2, you don't need water in your inhaler because you could make it not work. And your insurance company typically is not going to let you pick it up 2 weeks early because of how costly it is. So never put it in water, but they do tell you how to wipe it, the mouthpiece, and to storing it, and that sort of thing. And then here are Flovent, Qvar, and Symbicort. Of course, this Qvar is the multi-dose inhaler, which is going off the market. They're not making it anymore as of last month. But again, here's Flovent, Qvar, and Symbicort, and how to clean, how to prime. Now we get into the Sabas. So this is where it's really important to know when you've not used it for a certain amount of time that you have to prime it. Because with Sabas, you might go weeks, if not months, without using it. And if that's the case, then it should be primed before using it again if it's been 2 weeks. Ventolin actually makes mention if you drop it, you should also prime it. I'm not sure what it means by after washing. Wash plastic case in water weekly. I guess that's what it means. If you wash the plastic case in water, you should prime it by 1 puff. I was just thinking if you kept it in your pocket and washed it in the washing machine, you should prime it. It might not even work if you do that. But I find that, you know, when you're educating families and patients on how to take medicines, priming tends to be like down there on the bottom and even forgotten. So when I would mention about priming, I can't tell you how many patients would say, "What? never heard about that. Well, it's actually on the patient medication information inside the box, but we know how many people do or do not read those. So it is important that we as educators tell our patients about priming, why we prime, especially why we prime, and when to reprime. The other thing that I'll mention is about dose counters, and I learned that people don't look at those inhalers and don't know there's a dose counter on it, and therefore they don't know that they're supposed to be watching the dose counter. So another little tidbit, when you're talking priming, just remind them what the dose counter is and why it's there and why they should be looking at the dose counter. There are electronic dose counters that, for instance, with levalbuterol and Proventil that do not have dose counters, that you can purchase an electronic dose counter and put it onto your inhaler, and it will count down and let you know how much you have. And it is also one that can be transferred to the next inhaler. So it's not a one-time use because they're not inexpensive, but I think for those who use their albuterol frequently or just can't keep track of how much they use, then a dose counter is very helpful. So the factors that can affect how much dose comes out with a spray in regards to the multi-dose inhalers is if it's not priming. When it's not been used, the first dose may be reduced or completely not there. And that's because the propellant that's in the inhaler has just drained from the metering chamber. So again, if you shake it and you prime, you spray out, you should, after one or two, it may take more than one or two priming sprays, but you should be able to get your priming, after priming, to get a full spray. Now, I have had a couple of patients tell me that it just quit spraying, and I told them, take it to your pharmacy and show them. And they were able to get a new inhaler, although it was too early, but it was considered to be a manufacturer error, and therefore insurance would pay for it. So that's rare, but I'd say it must happen at some point in time, although it's probably infrequent. If there's no dose, or it's not noticed because it's still spraying the same, but I have had this happen where it was still coming out, but they were using their albuterol for symptom relief, and they were getting no symptom relief, although it's the same medication they used, and the one before and the one before that, they always had good results. I told them, again, take that one back to the pharmacy, and pharmacy gave them a new one. So it can happen, but it's not common. And in this case, the ingredient either creamed or settled and just was not able to get into the aerosol propellant. And tailing off where again, you're not getting, this is the other reason why you want to check your dose counter. So let's say you are at a 002 and you use your last two puffs that now bring it down to 000. You can keep spraying and getting a spray for up to 2 weeks after you hit 000 in some of these inhalers. Doesn't mean you have a lot of medication. So that's what tailing off means, is that you can still get spray, but there's no guarantee that you're having much, if any, of the medication. A large amount of that may be the propellant. So I learned a good lesson in explaining that to a patient after I realized she was, because of insurance and copay, she was continuing to use it for her child, and it was lasting 2 weeks past.